This is something we hear almost every single day in clinic. A person walks in with an MRI report and a tired face and says, "Doctor, my disc is gone, my neck is spoiled. It is just age and posture, right?" Let me disarm this without attacking anyone. Yes, age matters, posture matters, gravity matters. But if that was the whole story, then every person crossing 40 would be disabled. Here is the more useful truth. Your spine is not a stack of bricks. It is a living ecosystem. Discs, joints, nerves, blood supply, muscle, fascia, immune signals, and micronutrients sit in one loop. When that loop is underfueled, overloaded, and poorly coordinated, degeneration accelerates. When that loop is restored, many backs and necks become stable again, even if the MRI still shows wear and tear. And before we go deeper, you need one mindset upgrade that instantly reduces fear. Degenerative findings on scans are common, even in people with no pain. So imaging must be interpreted in the context of symptoms, exam, and function, not panic. So today, I'm going to give you a clinician-grade framework, a diagnostic filter first, then the treatment levers, then the integrative sequencing. Step 1. The diagnostic filter that prevents wrong treatment. Filter A. Red flags. Is this urgent? Before exercises, before needles, before supplements, you triage. If pain is paired with any of these, you do not stretch it out. Progressive weakness, foot drop, loss of coordination. New bladder or bowel changes, saddle numbness. Unexplained fever, weight loss, severe night pain that does not settle. Strong fracture risk, cancer history, serious infection suspicion. That is not fear, that is correct medicine. Filter B. Is this inflammatory back pain? This is where integrative rheumatology changes outcomes. Inflammatory back pain behaves differently from mechanical pain. Classic clinical features include often begins before 40, gradual onset, morning stiffness that improves with movement, pain that does not improve with rest, night pain often in the second half of the night. If this pattern is present, the spine is not rusting. The immune system may be driving inflammation at the sacroiliac joints, entheses, and spine. Then you actively look for the ecosystem clues that often travel with it. Psoriasis history, uveitis history, chronic gut inflammation or IBD symptoms, heel pain, plantar fascia pain, enthesitis patterns, alternating buttock pain, deep SI pain. And if suspicion is meaningful, you do not delay proper workup. Early management matters, and guideline-based care exists for exactly this situation. Filter C. Cervical spine can be rheumatologic too. People forget this. Rheumatoid arthritis can involve the cervical spine, and in some patients, it can create instability patterns that change what you do with manual therapy, exercise progression, and even how urgently you image. Also, there are inflammatory mimics of sudden severe neck pain, like CPPD around the dens, often discussed as crown dens syndrome, where management is medical and pattern recognition matters. So here is the diagnostic truth. Mechanical pain, myofascial pain, and inflammatory pain can coexist, but they should not be confused. Now, once you classify the driver, you treat with precision. The core model. Stop thinking posture. Start thinking tension plus tissue quality. Modern biology uses a useful concept called tensegrity and related mechanotransduction models. In tensegrity systems, structure is maintained not by rigid stacking, but by the balance of continuous tension and discontinuous compression. Clinically, this is why sit straight is often too shallow. Because the real issue is rarely one frozen posture, it is the baseline tension in the system and the capacity of the tissues carrying that tension. And that brings us to the most ignored organ system in spine care. Fascia, the body-wide network that can generate pain and stiffness. Fascia is not just packing material. It is a continuous connective tissue network that surrounds and connects muscles, bones, nerves, vessels, and organs. Modern reviews describe fascia as a regulatory system interacting with nervous system signaling, immune biology, and tissue healing. And it is richly innervated, meaning it can generate and amplify pain. A classic spine-relevant structure is the thoracolumbar fascia, which participates in load transfer and trunk stability. And fascia is sensory tissue, Studies examining thoracolumbar fascia innervation support the idea that fascia can be a real nociceptive contributor in low back pain. So here is the working lens. Spine pain is often a mismatch between load and tissue capacity. Fascia, muscle energy systems, and immune tone are major parts of that capacity. Now we go to the levers, the end-to-end treatment levers. Lever 1. Tissue healing biology. Micronutrients that decide whether rehab works. People think nutrients means bones, but spine resilience is also muscle endurance, fascia remodeling, nerve stability, and immune tone. Vitamin D. Vitamin D status has been studied in relation to low back pain and musculoskeletal pain patterns. Vitamin D is also studied in context of pain chronification and transition from acute to chronic pain. In surgical spine context, vitamin D supplementation has been studied for outcomes after lumbar fusion, including function and pain-related measures. Clinical translation. If someone has persistent spinal pain and repeated relapses, vitamin D status is a core variable, not a side note. Magnesium. Magnesium sits inside ATP biology, calcium handling, and neuromuscular relaxation. It is also required for vitamin D metabolism and function, which is one reason low magnesium can blunt response to vitamin D strategies. Clinical translation. If cramps, tightness, spasms, poor sleep, constipation, and anxiety coexist with spine pain, magnesium deficiency becomes a high probability piece of the puzzle. Zinc. Zinc is tied to skeletal integrity and bone mineral density in systematic review and meta-analytic literature. Clinical translation. If someone is not rebuilding well, has poor recovery, and labs suggest deficiency patterns, zinc is not a cosmetic nutrient, it is tissue biology. Copper. Copper is not trendy, but it is structurally important. Copper is required for enzymes such as lysyl oxidase that participate in collagen and elastin cross-linking. Iron. Iron deficiency is not just anemia, it is an energetic stressor to skeletal muscle, affecting exercise tolerance and muscle energetics. Clinical translation. If fatigue, breathlessness on exertion, cramps, and poor rehab tolerance coexist with back pain, iron indices matter. Do not look only at hemoglobin. Think ferritin and iron studies with clinical context. B vitamins, especially for nerves and energy. B vitamins are deeply involved in energy metabolism and nerve function. Deficiency states can present with neuropathic symptoms and weakness patterns that mimic or amplify spine syndromes. Clinical move, simple and powerful. Do not worship the MRI. Respect the blood work too. Vitamin D, magnesium, iron indices, B vitamin status where indicated, inflammatory markers like CRP, and metabolic markers often decide whether rehab succeeds or fails. Lever 2. The rehabilitation core. Train deep stabilizers, not posture fear. Exercise is not optional for spine longevity, but random exercise is not the same as targeted stabilizer training. Cochrane-level evidence supports exercise therapy as beneficial for chronic low back pain. Core stability training has shown advantages over general exercise for pain in meta-analysis level evidence, especially short-term. Clinical translation. For lumbar spine, think deep abdominal control, gluteal strength and hip stability, walking capacity and progressive load tolerance. For cervical spine, think deep neck flexor endurance, scapular control and thoracic mobility, reducing constant over-recruitment of upper trapezius and accessory breathing muscles. Your goal is not to freeze the spine. Your goal is to make stabilizers intelligent, so the system stops bracing 24/7. Lever 3. Myofascial trigger points and dry needling, the rehab accelerator. Now, we go into a major blind spot in spine care. Many cases labeled disc pain are actually myofascial pain patterns that refer pain into the back, hip, glute, or neck. Travel and Simons mapped classic trigger point diagnostic features and referred pain patterns, and they repeatedly emphasized that skilled palpation and pattern recognition matter. Trigger point scan refer pain far away from the actual site. Mimic radiculopathy symptoms in some cases. Increase protective guarding, raising compressive load on the spine. Where dry needling fits. Dry needling is not a miracle, it is a tool. Systematic reviews and meta-analysis have evaluated dry needling for low back pain with myofascial trigger points, showing short-term pain improvements across many studies. The integrative truth is this: dry needling can open a window. Exercise and movement retraining must occupy that window. Nutrition and sleep must support tissue remodeling. Otherwise, the system reverts. A clean clinician-grade integration looks like: assess and map trigger points and referred pain patterns. Dry needling or myofascial release to reduce protective tone. Immediate low-load movement and stabilizer activation. Progressive strengthening over weeks. Correct micronutrients so ATP metabolism and collagen remodeling can keep up. Safety note for the audience: needling should be performed only by appropriately trained, licensed professionals with sterile technique and proper screening for bleeding risk, infection risk, pregnancy considerations, and medical contraindications. Lever 4. Acupuncture protocols. How we use it inside a modern spine plan. Acupuncture, when used clinically, is not mysticism. It is a neuromodulation and tissue regulation input. High-quality meta-analytic evidence supports acupuncture as more than placebo for several chronic pain conditions, including back and neck pain, with effects that are meaningful but not magic, best used as part of a broader plan. The practical acupuncture protocol logic we use. This is not about one point, it is about a sequence. Classify the pain driver: mechanical dominant, myofascial dominant, inflammatory dominant, often mixed. Choose the acupuncture dosage based on stage: acute spasm and pain amplification. Calm the system, reduce protective tone. Subacute phase: restore movement variability and sleep. Chronic phase: combine neuromodulation with progressive strengthening and breathing mechanics. Combine local plus regional plus system regulation. Local and segmental work for pain modulation and tissue tone. Myofascial trigger point work when referral patterns dominate. Distal regulatory points to downshift sympathetic overdrive and improve sleep quality and recovery. Use electroacupuncture selectively when the pattern is persistent, centrally sensitized, or when neuromuscular re-education is needed. Electroacupuncture can be used as a structured stimulus, always with a rehab plan following. Always close the session with movement. The session should not end as relief only. It should end with a small movement assignment that anchors the new pattern. Breathing drill, deep stabilizer drill, gentle range retraining. That is how acupuncture becomes a rehabilitation accelerator instead of a weekly dependency. Lever 5. The upper hub, jaw, tongue, and breathing mechanics for cervical spine load. A huge percentage of chronic neck pain patients are unconsciously clenching. Jaw tension, tongue posture issues, forward head patterns, and mouth breathing load the neck all day. There is published evidence examining associations between head and cervical posture and temporomandibular disorders. Here is the simple clinical logic. If every breath recruits neck muscles, the neck never gets rest. So the practical checklist becomes: nasal breathing retraining when possible, diaphragmatic control so accessory neck muscles can downshift, jaw unclenching awareness, especially during screen time and driving, sleep breathing screening when suspected. This is not alternative, this is load management. Lever 6. Gut pressure, gut inflammation, and the lumbar spine. Many people notice this pattern. When bloating flares, back pain flares. Functional bloating and distension are discussed within disorders of gut-brain interaction involving visceral hypersensitivity, altered gas handling, and motility patterns. Mechanically, increased abdominal pressure can change bracing and posture. Immunologically, dysbiosis and gut barrier issues can amplify systemic inflammatory signaling and pain sensitivity. Practical takeaway: if chronic low back pain coexists with IBS symptoms, reflux, bloating, or food trigger patterns, the back may not fully stabilize until the gut calms down. So a spine plan often needs reducing ultra-processed foods, gradually increasing fiber diversity as tolerated, protein adequacy, personalized trigger identification. The rheumatology protocols layer how we do this correctly. If the pattern suggests inflammatory disease, you do not treat it like posture. Axial spondyloarthritis, the high-value protocol principles. Guideline-based management emphasizes education and consistent exercise. NSAIDs as first line for many patients. Escalation to biologic therapy for persistently active disease in appropriate patients. Monitoring extra-articular features and comorbidities. Rheumatoid arthritis with cervical symptoms. If a patient has RA and significant neck symptoms, you do not assume it is routine spondylosis. Cervical involvement and instability can exist. So the rheumatology protocol is identify inflammatory pattern, confirm with the right imaging and labs, control disease activity appropriately. Then layer rehabilitation, fascia work, needling, and nutrition on top for long-term resilience. This is the integrative strategy. Pharmacology controls immune fire, rehabilitation and nutrition rebuild structure and function. The end-to-end sequencing, how you actually win long-term. Here is the complete drill in the order that tends to work best. Step 1. Classify the driver. Mechanical dominant, myofascial dominant, inflammatory dominant, or mixed. Step 2. Rule out red flags, then confirm inflammatory patterns if suspected. Step 3. Reduce baseline protective tone. Acupuncture and myofascial work. Dry needling when trigger points block progress. Sleep and breathing downshift. This is your opening window. Step 4. Immediately rebuild stabilizer intelligence. Exercise therapy is not optional, it is foundational. Step 5. Fix tissue quality so the rebuild can happen. Vitamin D, magnesium, iron indices, B vitamins when indicated, zinc, and copper status when clinically relevant can change how well tissues remodel and how well nerves behave. Step 6. Reduce inflammatory load, including gut and metabolic drivers. Step 7. Maintain consistency. The best spine strategy is rarely aggressive. It is precise and consistent. You reduce baseline tension, you improve tissue quality, you increase stabilizer intelligence, you normalize breathing and jaw mechanics. You treat trigger points when they block progress. And if the immune system is driving the fire, you address it early with proper rheumatology logic. Final caution for the audience. This is education and strategy design. It does not replace individualized medical care. Do not stop medications, self-prescribe high-dose supplements, or delay urgent evaluation solely based on a video. Spine decisions should be made with qualified clinicians who can evaluate red flags, neurologic deficits, imaging, and whole body context. Different perspectives can coexist, but tissue biology still has rules.